I can't believe it. I am finally back. Uh-oh. I had to hear myself say it twice. Heard by herself first time and then that time too. Anyway, it's been too long. We're ramping back up. I guess it's important for me to at least give you some idea of kind of what's been going on. But, as you know, this is not my only job, and that I, have a company that I have to manage and deal with, and contracts and personnel and cases and inadequate staffing when that happens. And I'm busy, really busy, to the point where it just became overwhelmed, couldn't keep up with everything. Everything was failing, so I had to pull back somewhere, and this was where I decided to pull back a little bit. But we now have, and I'm going to be introducing you to somebody here momentarily, but we now have the system kind of fixed. We've retooled the PerfWeb infrastructure, the part of PerfWeb that you see, the part that's in all of the electronics. And then we have also found a new studio, and the new studio is going to be in a better location that is far more convenient for many of the faculty members that we want to include in our programming. One of the things that I had decided was to have this studio where it is and use it as basically a place to entertain and have conferences and things like that virtual, but to make it so that it's a day event, if you will, for the faculty that would come out or any of the invited guests that we might have. But unfortunately, that necessitates you doing it on the weekend. It wears off like everything else does. It was great fun in the beginning, but now it's really hard to get people to come all the way out here because we're too far out of the country, right?
It's pretty fun.
And so, so that's a reality. So I've gotten a place much closer to the medical center, hospitals, to facilitate that being a resolved issue. And the new studio is going to be set up very different to make the ability for our production staff to show different aspects of what's going on within that studio for demonstration purposes and all of that. But listen, bottom line is we're here for good. We're here to stay. The PerfWeb programs are going to continue to grow and get better and better with time. And having you guys as part of that process is so incredibly important and valuable to me. And I would appreciate anything you guys can do at all. Call in, participate, send me emails, even if it's to tell me that I'm wrong and I don't know what I'm talking about. I don't care. Send me anything, okay? Any attention is better than no attention, right? Even bad attention is better. So with all of that said, let's get with the standard opening remarks. You know I have to do that. So to contact us, you're going to go to contact@perfusioneducation.com and email us if you like. Our call-in number is here, and that is going to be 5358. That's 832-239-5358. And then if you look at our Chiron, is that what that's called, a Chiron? Yeah. The scroll bar, all of the information that I just gave you is going to be there continuously, so you can just locate it and find it at your leisure, if you will. And then I'd like to talk to you about our critical care app for perfusionists and for ECMO and critical care nursing. If you go to the App Store, this app is very comprehensive. It has all of those things you see there: perfusion, ECMO, hemodynamics, clinical calculators, IV rate calculator, dose and rate calculator, and conversions. You can just use your phone and do the QR code right there, and you'll get it. It's $2.99, and there's a separate standalone app for the IV rate calculator that you can get for 99 cents. That's surprisingly, that's the more popular one. I don't think it's because it's 99 cents, but because I really do like that app. I use it every day, and it has been very useful for me. Our PerfWeb podcasts are located on whatever your favorite streaming software streaming podcast platform is. And they'll switch that here in a second, I'm sure, pop something up. Does something pop up with it? I'm just waiting. Normally does, just isn't today. That's that new tooled web infrastructure I talked about. We really got that. We got those details ironed out really well. Anyway, whatever your favorite podcast streaming platform is, you can find us there. Type in PerfWeb, it'll pop up. You can listen to us while you're driving in your car. Okay. Now, let me introduce you, if I can, to. Did I get everything, David, or did I forget anything? Good. Let me introduce you to you, if I may, one of our newest faculty. This is Samir Patel. He is a medical doctor, graduated from
Windsor University.
University, and practiced in India in a stroke unit.
Yep.
And then you came back here to the United States.
Correct.
And you decided that, going through the process to practice here was going to be more challenging than what you wanted to do at this time. So you applied for and enrolled and was accepted and have completed successfully the training program, perfusion training program at UT,
yes,
and the Texas Medical Center, University of Texas Medical Center,
yep,
with the in the McGovern School of Medicine.
Correct.
And so you're a graduate from there and now working with HET.
I am.
And you've been an incredible asset, a new asset to the company. I think that I'm really looking forward to a tremendous relationship with you over time. I've really enjoyed working with you already. And I will tell you that Samir is a very capable, qualified, intelligent person, professional, and I'd let him do my case any day. He's really a good guy. So with all of that said, we're going to switch things up because, again, we're very well organized. I told you we have a new program, and we're going to swap the lectures today. We're going to do hemoglobin thresholds, finding balance in perfusion practice by Dr. Samir. He's giving that lecture. I'm going to give my RAPP lecture second. And then tomorrow we'll also have some changes in the schedule. It makes more sense for his to go first. And his is actually listed as both lectures today, but I'm doing the one on RAPP, if you don't mind. And with that said, if you'd like to say anything, you're welcome to, or you can dive right in, whatever you want to do. The floor is yours, sir.
All right. Well, thank you, Joe. Yeah, well, that was a great introduction. Thank you so much. The feeling's mutual. I'm loving my time at HET, loving perfusion. Leaving medicine, I was left with a big question mark on what to do, but I don't know, perfusion has more than filled that void, and now I'm trying to give back what I've learned, you know?
Yeah, and you have a really interesting perspective, too.
Right.
In fact, this conversation that we had today, what was that you were talking about on fluid balance, on fluid assessment?
That's going to be
the test.
It's a diagram called the Darrow-Yanet.
Darrow-Yanet
diagram. It kind of explains like fluid shifts. Like if you add isotonic, if you gain an isotonic, if you lose isotonic, if you gain hypertonic fluid, hypotonic fluid, it explains what happens in the body to the ECF and the ICF. And to me, it just boggles my mind that we as perfusionists, who hemodynamics and fluid balance is the central core of what we do.
No kidding.
And they don't teach us this diagram.
I don't know the diagram, and I've been doing this a long ass time.
Right.
I thought I actually knew something.
Yeah, and that diagram is like ingrained into you.
And that is so important, a concept to tell everybody, is even after 45, actually it's longer than 45, it's a long time that I've been doing this job, and I still learn stuff. And that's what this program is intended to do. It's supposed to teach us things. Not necessarily, I have very strong opinions. You have opinions, and that's what I like about you, okay?
Right.
We have very strong opinions about what we think is right. If you don't think you're the best perfusionist and the way you do it is the best, then you shouldn't be a perfusionist at all. I mean, let's be real about this. And there's 1,000 different ways to do the same thing. And there's so many variables here and there. The issue isn't what we know.
Right.
Because if you compare what we knew from 5 years ago or 10 years ago to today, we have the amount of things we have learned is almost it's staggering the amount.
Right.
But what scares me is how little we actually know. It's what we don't know.
Absolutely.
And that's why when I hear people say things like, you should never do that. Really, I don't think that's right. You should never do that. Why? So let's really explore this. We're going to talk about that a lot because I'm going to say it. You should never RAPP. I'm just going to say it.
Yeah.
This is ridiculous. I don't even believe that we're still sitting here having this discussion. It's insanity in my view. And ultrafiltration being the cause of renal compromise or acute kidney injury is absurd on its face. Now, can I make it? Can I make it do that? Yes, I can.
Absolutely.
I can make it. I can hurt you all day long.
Absolutely.
But that's not what we're talking about here. And that's where I get frustrated with this idea of always and never, shall and should, all of that stuff. But we're going to get into that because one of the things I'm going to do with PerfWeb this year is I am going to take PerfWeb and we are going to take the AMSECT guidelines one by one. And I am going to look at every one critically, and I'm going to give you my thoughts about each one of those. And my panel will give their thoughts, and their thoughts are their thoughts. Nobody comes to this program ever being told you have to say this or that or can't do this or that.
Right.
This is wide open. You want to talk about open source? This is wide open. So I welcome all of you to call on that phone line, chat on here, do whatever you want to do. But let's make this real. Let's make this serious. Let's make this enjoyable. And let's make this informative. That's what I want to do. So sorry. Go ahead.
No, you're fine. I mean, that's what we're here for. You can talk whenever you want.
I get very impassioned about some things.
And as you should. That's the nature of our business, you know.
I think it is.
I mean, if you're not, like you said, if you're not passionate, then you're not thinking, right? You're not actually looking at what you do, and you need to be able, why, right? You said why.
Yes.
Tell me why, because the
Yes.
why is what's important.
Yes.
Like, I'm going to basically, in this next lecture over hemoglobin, I'm going to give you guidelines and stuff, but I'm also going to tell you that, hey, you know, it's kind of patient to patient. You know what I mean? Like, okay, so there are certain patients where we shouldn't transfuse. There's certain patients where we should. It doesn't mean that you look at a certain hemoglobin and be like, oh, transfuse.
Or
you know,
look at a hemoglobin and say, don't transfuse.
or don't transfuse.
That's
right.
worse.
Exactly. So
in my view.
And that's the case for all of medicine, Joe. It's not just hemoglobin. It's not just ultrafiltration or RAPP or any of these things, you know? I mean, that's the beauty of medicine is we're all different, right? Like your physiology is not at all the same as my physiology.
It's similar.
It's similar, yes. And that's where those guidelines
But
come
there's
from.
these nuances that make it different.
And that's what drives treatment, though, is the nuances.
Exactly.
Right?
Exactly.
Like,
That's where judgment comes in.
exactly.
Yes.
You know?
Hey, David, I don't know how to put his thing back up on my iPad. His thing. So like, remember you had them married together so that I could see his slides?
Yeah.
Okay. Oh, thank you. You're so smart. Okay.
So, yeah.
So I totally agree with you. Thank you. Thank you for
yeah,
that. That
I
was
mean-
very good. I can't wait to get Daphne here.
Yeah.
Wait until you guys see some of our new faculty.
Yeah.
It is going to be seriously kick-ass.
Yeah,
okay, go ahead. I'm
definitely.
so sorry.
No, you're
Please.
okay.
I got to stop talking. Turn my mic off.
No, don't turn his mic off. Let him talk. You could just, hold for a sec. Let me get through some of this, or we'll never get through it.
Go ahead.
All right. So, all right. So what are we going to talk about today? Hemoglobin, as I've alluded to a few times now, Joe also alluded to. Basically, what about hemoglobin? It's hemoglobin thresholds. We're basically going to talk about, should you transfuse? Should we not? Stuff I've already alluded to briefly. Got some objectives for you today, so you don't feel like you're not getting something out of it. At least let me tell you what you're going to get out of it. You're going to get some stuff out of it, You're going to understand hemoglobin. not just what it is, but why it's so biologically brilliant. I mean, it's more than a lab number, you know. Basically the molecular VIP of oxygen delivery. You're gonna know the thresholds we talked about in medicine, perfusion. You know, more importantly, understand why those thresholds are not engraved in stone. They're kind of guides, not commandments. Kind of like I just said a second ago. You know, they're each person's different. You got to go with the flow. You got to go with the person. We're going to evaluate, you know, whether tissues are getting the oxygen they need, because you're not just moving blood, you're delivering life, right? That's what we perfusionists do. You need to decide when to transfuse, and more crucially, you need to decide when not to transfuse, you know? Sometimes restraint is the smarter move, especially when it comes to blood transfusions. I'll get into that in a little bit. It's not as simple as we just give blood. There's a lot of little things that happen when you do it that the body just does not like, which makes sense because it's, you know, the body doesn't like anything that it is not its own, you know.
It's just, what is it like less?
Exactly, and that's
does it prefer anemia and its associated issues, or does it prefer to have this blood?
Exactly.
So which one's going to hurt worse?
And that
or less?
And that's the name of the game. That again is all of medicine. You know, it's not just hemoglobin. I mean, there's a lot of drugs, a lot of medications, a lot of treatments we do that is the same thing. They have 100 million negative side effects, but that one good side effect, is it worth it? You know, that's what we evaluate.
Could be.
You know, most of the time it could be, and that we hope that's why we do it, you know, honestly.
Well, we were giving people remdesivir.
Exactly, see?
How many people did that help?
That's a whole different other discussion, Joe.
I mean, but it's a reality. But it's a reality.
Yeah, COVID was a trying time.
But we still do all kinds of things. Look, we had a case yesterday.
Right.
I won't get into the where or who or anything like that.
Sure.
But this dude, you know, he had a really messed up right coronary, and he was just shitty protoplasm, just not, you know, just kind of grubby.
Right.
And the case took much longer on pump than it ever does for this particular surgeon. And he did, and it was only four bypasses. So he did four, two, a sequential on the right, and which was really a weird sequential, endarterectomies,
right.
an OM, and a LAD.
Right.
And the anesthesiologist was like, okay, I'm gonna do a Rotem or a whatever version of thromboelastograph that they do.
Right.
And it came back with, you know, somewhat low on the fibrinogen scale. Like,
okay.
Fibrinogen was recommended.
Right.
So, you know, I was like, well, I wouldn't get anything. I mean, I think we should wait.
Right.
You know, how do we know whether he's going to bleed or not?
Right.
And so, you know, there was all this debate, and they ended up ordering cryo,
which takes forever.
Cryo, FFP,
right.
and platelets.
Okay.
And we came off pump, gave the protamine, and I heard the surgeon. He said, "This looks awfully dry." I mean, I didn't expect this. And I mean, only half the protein was in it. It was already dry.
Right. So did you need all those products?
No, ordered? But they gave it anyway.
Sure they did.
But they gave it anyway. I don't think they should have, but they did.
Sure.
Now, were they wrong? I don't know. If the patient didn't bleed, then they were, without giving them, then yes, they would have been wrong. But we would have had to done that test.
Sure.
They didn't bleed, and there weren't any problems. So therefore, one could argue, they made the right choice. Okay. But I think we didn't need it. But there's no way to prove that.
Well, no, right? And
at this point, no.
And that's kind of like, it's more of a cover your ass thing, I think, at that point. You know what I mean?
But I don't think we should practice that way.
Absolutely not. But that's the society we live in.
True. Okay, going on.
So those objectives are what we're going to kind of talk about, you know. Let me move on to the next slide. All right, so hemoglobin, you know, what is it? You know, well, it's the star of the show for sure. For oxygen delivery, we're like a heist movie. Hemoglobin would be like the mastermind, the driver, and the getaway car. You know what I mean? It's not just a number in the CBC. It's, kind of like a biochemical logistics system and basically keeps your cells and your tissues like happily respiring. You know what I mean? So here's the science that we need to get out of the way, just because I need you guys to kind of understand what hemoglobin is. So what is the hemoglobin molecule? More importantly, we're going to be talking about the hemoglobin A molecule. And more specifically than that, it's going to be the A1 molecule. There's a bunch of other hemoglobin molecules. You got, B. You got hemoglobin F, which is like fetal hemoglobin. It's like the thief hemoglobin. Let me just tell you a little bit about what that one is. That one is basically, I always tell my wife, she's pregnant right now, she's always waking up tired and stuff, and I'm trying to tell her why she's tired. And what it is that fetal hemoglobin, it binds oxygen with more affinity than regular hemoglobin A, which is our adult hemoglobin. So babies need this because they don't oxygenate. They don't go to their lungs, right? They're literally stealing oxygen from the mom's blood. It's kind of how they work. So they go into the placenta, they kind of come around, they kind of just jack oxygen. And I tell my wife all the time, she wakes up, she's like, I'm tired. I'm always tired. I'm like, yeah, man, because your baby's jacking all your oxygen, And that's fetal hemoglobin. So yeah, just, again, we don't have that. Just thought I'd throw that out there. Shout out to my wife. So yeah. So
is she watching?
I know she's working, but I am going to have her watch the recording.
She may better be watching.
She said she'd tune in from time to time. So, yeah. Again, okay, so adult hemoglobin A, is kind of the main hemoglobin. It's like 98% of our hemoglobin. It's got 4 globin chains on it. It's got 2 alphas, 2 betas, and each chain is attached to a heme group. In the middle of each heme group is iron, the magical iron, everybody knows about iron. And the key is that the iron atom is actually what binds the oxygen, all right? So one hemoglobin molecule can carry 4 oxygens. Now, multiply that by 250 million hemoglobin molecules per red cell, and then roughly by 25 trillion red cells in the body. Well, now you see how much oxygen you're circulating around. You guys can pull the calculator out and do that math. It's too many zeros. So hemoglobin, in a general nutshell, is responsible for 98% of the tissue, of oxygen delivered to the tissue. The other 2% is dissolved in the plasma. That's where we get that PaO2, the partial pressure of oxygen in our arterial blood, which is helpful, if you're trying to oxygenate a whole human, you're going to need the hemoglobin. That little 2% is not going to do much. It's like trying to fill a swimming pool with like a turkey baster. That's just not going to get you anywhere. So if your hemoglobin's low, it doesn't matter if your PaO2 is 400, 600, 800. It doesn't matter what it is. You're just not going to oxygenate, and that's just the name of the game. You're just not going to be able to do it. So it's critical for us, in perfusion, that you understand this, that it is hemoglobin. Especially us going forward in this lecture, I'm going to be making a lot of references to like PaO2s, things like that, saturations. I'll break it down a little for you guys as we go on, but that's kind of what it is. Without delivery trucks, which is the hemoglobin, you can't deliver. Okay. All right. So everybody's favorite graph, especially if you're a student of medicine of any type. You have seen this graph. It is the oxygen hemoglobin dissociation curve. This is the name of the ball game right here, guys. It's a curve that, in essence, really only does two things. It shows us how clingy or how generous the hemoglobin is with the oxygen. Will it hold on to it? Will it release it? And factors drive that. And I got them kind of written here, you know what I mean? Like the factors that drive it, which we'll go over. So, at a PaO2 of like 100 millimeters of mercury, think, the lungs, hemoglobin's almost fully saturated, all right? Nearly 100%. But at around 40 millimeters of mercury, you start you know, it's what you see in most tissues. So it's not like you're going to see what's in the lungs. When you get down to the feet, it's not at that saturation no more, you know? So down there, it's about 75% saturated, which means it's already let go of about 25% of the oxygen, you know, and that's the oxygen you're actually going to use. So, you know, let's talk about what can shift this curve. You know, I talked about things can make it more clingy, less clingy, you know. Right shifted curve, that little brown colored line to the right, you know. That's called a right shift.
You know you can draw.
Oh, yeah, I didn't know. Okay. Can I draw on this?
Yeah.
All right, so, hold on, let me turn it on.
It's drawing.
Is it? Okay, yeah. So, yeah, this curve right here is the brown line, the right shift. We'll start off with that. So, the right shift, it lets oxygen off more easily. This is the one where it's not as clingy. It lets it go, you know. Things that cause it, you know, are increased CO2, acidosis, which is caused by increased CO2, hyperthermia, elevated 2,3 DPG. Basically, the harder the tissues work, the more oxygen hemoglobin has to kind of give up, you know. So right shifted curve is like a team player, you know. And then,
I'm gonna throw you.
Yeah.
I'm gonna throw a curveball at you.
All right.
Okay, and I need to do this. I need to do this for myself. So increasing PCO2. So when we talk about both this right shift and we talk about cerebral blood flow,
Yeah.
we all understand that increasing your PCO2 will increase the cerebral blood flow.
Correct, by vasodilating.
Correct.
Right.
But the influence of that is actually the hydrogen ion concentration, not the CO2 level.
Correct.
Here's my question. If the patient has a compensated respiratory acidosis,
Sure.
and their pH is normal,
Right.
their hydrogen ion concentration is normal because of the
Bicarb.
increased bicarb,
Right.
does that influence still exist? Elevated CO2 increasing cerebral blood flow. So if I were
Yes.
if you increase the CO2, but I give bicarb on top of it and get the PCO2 to 50, but I have my pH is 7.4 because my bicarb is now 32, does the PCO2 still have an influence on cerebral blood flow?
It should, because you still are going to be somewhat acidotic. You have to remember, Joe, that no compensation is complete. You won't go back to 7.4, but you'll get pretty damn close. But it won't ever be 100%.
Okay.
You know what I mean? So you will still be right shifted, you know, on your curve. That's kind of the thing about our body. It'll fight hard to get back to normal, but it won't quite get all the way there. You know what I mean?
Gotcha. With a compensatory mechanism. Thank you. You answered my question. Thank you.
Okay, great. So let's talk about left shift. Basically, the opposite of right shift. That's this one right here. It holds on to oxygen more tightly, and all the opposite stuff will make it go that way. You know, decrease in temperature, alkalosis, low CO2, presence of fetal hemoglobin,
Methemoglobin.
or methemoglobin, right? So those are the left shifteds, all right, and those are the ones where you hold on tightly.
Carboxyhemoglobin.
Any of those stuff, right? So on bypass, you're typically cooling, you know, the patient, and often hyperventilating them too. So that's a left shift double whammy usually, right? I mean, and we do this regularly without any. It's still on there. We do this regularly, you know. Your hemoglobin's grabbing oxygen like it's toilet paper, you know, during the pandemic, refusing to share, you know. But you won't see this on a pump console, you know. There's no flashy light that says, "Hey, hemoglobin's hoarding again." You know, you gotta read the room. You know what I'm saying? You gotta look at the labs, the physiology, perfusion parameters. You know, this is where science kind of becomes an art. You know, this is why we get paid the big bucks, right, Joe?
Enormous amounts.
Yeah,
enormous amounts. I don't even know what to do with it all. I'm burning it. Truckloads of it.
Truckloads of it. Everybody wants to be a perfusionist until everything goes wrong.
Yeah.
And then the whole room's looking at us like we need to solve the problems of the room.
Yes, we do.
All right, next slide. Hold on 1 second. Got it. Yeah. Normal hemoglobin levels. These levels, I mean, it doesn't matter what source you look at. You're always going to get a little variation in it. Such as, look at my slides. See, where I got my first information, it was like 13.5 to 17.5 is normal. But then if you go, it'll say 13 to 16 on the pick. So again, these normal ranges, they're kind of just that. They're just, you got to take them with a grain of salt. We try to get around that, you know what I mean? With adult males, it's usually like 13.5, 17.5-ish. Adult females, it's like 12 to 15.5 grams per deciliter. Let me throw that out there since we're being more official. Most of the time, I will omit saying grams per deciliter. I'm just going to throw that out there also. I'm just going to talk numbers. Children, they're variable, but usually between 11 and 16. Now, newborns, little guys are overachievers. They usually have hemoglobins over 18, thanks to that whole fetal hemoglobin thing that I have beautifully alluded to. Now you see why I alluded to fetal hemoglobin early on. So let's talk the reality of it, though. You know what I mean? Like on pump, once you're like primed, you know what I mean? Like with 1 or 2 liters of crystalloid, depending on if you RAPP or not. Joe will get to that later. But usually, yeah, we got 1 or 2 liters of crystalloid in that prime, and we go on pump, all about to drop all that crystalloid into the circulatory system, dilute out the hematocrit, dilute out everything. I mean, most of our patients end up falling to like a 6 to 8 range, on our hemoglobin, and that's not instantly alarming, but it's worth tracking, We'll pay attention to it is what I'm getting at. So you have to remember that it's oxygen delivery, DO2, that's what really matters. Mm-hmm. You know what I mean? That's the name of our ball game. Every other number is just kind of a reference point, and we'll play around with those numbers, whether it's flow, whether it's hemoglobin, whatever it may be. But as long as our DO2 is good, then, and I'll get to DO2 a little more. We'll talk about it a little more in depth, as we go on. I'm just kind of alluding to it so that when I get to that slide, you're not completely alarmed and bombarded, because that slide got some math on it. And yeah, better to know a little bit before you get to the math. So, what are some other tools that we got? So DO2, how can we know what we're doing if this 6 to 8 is good enough? Like how can we know? Some other stuff that we got things like SVO2, our venous saturation. Is it that's basically the oxygen coming back from the tissues. So is there enough oxygen coming back from the tissues? That's a question we'll ask. Lactate's another thing that we can look at. Are our tissues in anaerobic metabolism? If they are, then lactate's going to be going up. That's a red flag usually. NIRS, that's another thing. Brain sats. Is it getting enough love? Is it getting the perfusion it needs? Urine output. I'll talk a little bit more about these a few times in this program, but I just want to touch on them now. These 4 things are important. Anytime we look at a low hemoglobin, we're looking at these 2. We're not just looking at hemoglobin. You should not just be looking at hemoglobin. Let me be a little more assertive in what I say. Hemoglobin is not the whole story. Okay. Again, DO2. Are we delivering oxygen? If we are, then oh well.
And our app has DO2 and DO2I.
It does. And
you can look it up real quick.
It does.
In fact, in my RAPP, you're going to see some really interesting information.
Yep.
About that very thing.
Perfect. So, in patients that we usually deal with in the operating room, patients with cardiac disease, especially those with like limited ejection fractions or CAD, coronary artery disease, the margin for error is a little bit thinner. You know what I mean? They tend to have a higher threshold for like transfusion and stuff like that. So we'll get into all this as we go on. So now, this is one of my favorite metaphors. in medicine. The Goldilocks zone. And there's Goldilocks. You see her on the screen. So, for those that don't know, the story of Goldilocks and the Three Bears is she's like this little girl. She gets lost in the woods, goes into some random house that three bears own, and she sees like porridge. She sees like a chair and some beds or something like that. Anyways, she sees 3 cups of each, 3 chairs, 3 beds. She like tries out all the porridge. One of them's too hot, one of them's too cold, one of them's just perfect. Bed too, gets on the beds. One is too hard, one's too soft, and then the little babies is just perfect. Well, hemoglobin's kind of the same way. Too low, and you're starving the organs of oxygen. You're on a fast track to lactic acidosis, organ dysfunction. Somebody will be paging nephrology. But then if you go too high, well, now you're creating, now you're making your blood into like a syrup. Microcirculation slows down, viscosity raises. You basically created a sludgy like traffic jam. You know what I mean? So just right. That's the key. You know what I mean? You gotta figure out that sweet spot. So let's be honest though, like I've said earlier to Joe, these transfusions, they're not free. They come with some side effects. Trolley's one of them, which is transfusion-related acute lung injury, basically like an inflammatory lung grenade that can go off. You get hemolysis, immunosuppression, infection risk, iron overload, especially if you're given like multiple transfusions. I did tell you guys what the central core in all this is. It's iron, right? So imagine
and it is toxic.
Yeah, and it's toxic. Oh Lord, it'll go. It'll go everywhere, deposit in things, and it's a metal. So you don't want any part of that. The condition of it is hemochromatosis, I think. Yeah, That's the one where iron goes, and if you got too much of it, it'll deposit in all your tissues, various organs. And this is a heavy metal. Even in your blood, I know we kind of think of it, but it is a metal even in your blood. You taste it, right? When you bleed. Like if you ever taste your blood, that's the iron. You'll taste that iron. So the Goldilocks zone, you want everything to be, like I said, in the right range. You know what I mean? So what is the right range? Is there a right range? Keep in mind, what I'm going to throw out here, as me and Joe alluded to earlier, they're just kind of reference guidelines, You got to kind of play it by ear, patient to patient. Conditions, their pre-existing comorbidities, it all depends. Very much just remember, these numbers are what the books say. And sadly, when you're in the OR, it almost never goes according to book.
And when it comes to transfusions, the person who, I don't know who actually gets credit for coining the phrase, but
right.
The damned if you do, damned if you don't.
Yeah.
You give the transfusion and,
Yep.
Oh my God, but look at all the bad things that happened because of that. And you don't give it. And oh my God, look what happened because we didn't
give it. Exactly.
You just can't win.
And no, there's no winning. So usually, like I said, 6.5 to 8-ish, you're generally okay. As long as all those other 4 little things I talked about, your SpO2, your lactate, your NIRS, your urine output, if all that's good, then you're good. Below 6.5, now you're talking. It's usually considered a danger zone, unless of course your DO2 is like amazing. Like you're above like 325, 350-ish, man.
And I'm going to really aggravate you when I say this, because what I try to explain to people, and maybe you can even add it in if you'd like, is that when we're hemodiluting the hemoglobin like that, it isn't just the hemoglobin we're diluting.
No, we're diluting everything.
Everything.
Yeah, and the proteins, the coagulation factors,
exactly,
everything.
Exactly.
Everything, yeah.
Exactly.
I'm sure you're going to get to that, when we talk about ultrafiltration and some of these topics.
What I found is
forward.
that I can't get, we can never get to everything. There's so much. It's so involved. We're just going to keep talking about this for until we're both like, I'm going to be dead, just sitting here dead, and you'll still be talking. I'll be right back.
See, so, go ahead. So above 9, grams per deciliter. Probably unnecessary unless there's bleeding or instability or something like that. Unless you're active bleeding, you don't really need to worry about it. That is a more than adequate hemoglobin. This is kind of where your perfusion judgment shines. You know what I mean? Like, ask yourself, is the patient compensating? Where are my SvO2 and my lactates trending towards? Are they going down? Are they good? We're not trying to win a lab contest. That's not what we're trying to do, Like, So, as Joe, who is no longer here, but I will carry us forward. I don't need Joe. Just joking. So, as Joe kind of alluded to earlier, hemodilution, as I also was talking about, because we primed that circuit with so much crystalloid, and we're going to dilute out everything. That's kind of what we do, We're not just giving a gentle rinse. I mean, we're actively reshaping, the patient's intravascular landscape. It's not just like greatly, your average prime is around 1 to 2 liters, I said earlier, One, if you're like running out, you got to run out to get to 1, and that's most of us, we run some volume out now. We don't just go on with the 2 that we use to prime our pump. Most places don't do that anymore. Now, whether you're wrapping or venous wrapping or whatever, that's on you and your institutional protocols or your anesthetic protocols or whatever. If you get it below that 1 liter, but when you mix all that crystalloid in, like Joe said, you're going to dilute more than just your RBCs. You're diluting platelets, clotting factors. More importantly, you're diluting the proteins. I mean, that's huge. The effect that has on going forward, it's huge. That's another subject. I'm not going to talk about oncotic pressures and all that, but that's a whole nother discussion that I cannot even try to get into right now. No, we're going to, correct, we are going to. Definitely going to, yeah,
as we
absolutely
continue with this.
And because for me tomorrow I'll be giving a lecture on fluid dynamics, stuff like that. So we'll get to it. I'll be talking about it. So now, it sounds like a bad thing, right? Like all this stuff I just talked about like, ooh, we're hemodiluting with a liter, but it's not all bad, okay? Like, we do this on purpose, actually, and we have to do it. It's our circuit demands it. It demands the lower viscosity because it's easier to pump, lower shear stress, less workload for the heart too. These sick hearts, they don't. We need to give them some rest. This is how we do it. We help reduce myocardial oxygen demands, during periods of ischemia, stuff like that, But like I said, there's a price. We're gonna dilute out that hemoglobin. Our oxygen carrying capacity is gonna take a hit, more than a hit. And it gets slammed by a sledgehammer. And if you don't adjust your flows or you don't optimize extractions, you're gonna sneak into tissue hypoxia before you even know what the hell's going on. So what do we do about that? Now, there's a couple things you can do. One of them is what we're going to talk about next. Again, controversial topic. You either live by it or you die or you hate it. That's kind of the way it goes. But RAPP, retrograde autologous priming. Joe, who obviously hates it, he's already made that very clear. I as well support Joe, and I don't like it. I'll let Joe get to that, and then I'll also chime in on why I personally don't like it. But it's where you steal, your own patient's own blood to displace part of the crystalloid prime. Sounds genius. Nah, it's got its ups and its downs. But again, it's all about that. The whole point of that is just to get rid of some of this prime volume, increase your oxygen carrying capacity. Another one is ultrafiltration. We're also going to talk about that tomorrow. DO2, it's like I said, name of the game, monitoring it. Some of these fancy new pumps, man, they can just flat out tell you the DO2. It's pretty nice. If you guys got Epic in your hospitals, that also has a part where as long as it's pulling, the variables you need, such as flow, SaO2, PaO2, it'll calculate it for you. Hemoglobin, as long as you are inputting your hemoglobin, because some of the, like for instance, ours, for us, we use point of care, right? And for us, our point of care doesn't transfer until you go put it on the dock. Once you go and you put it on the dock, then it'll transfer. And then if it has hemoglobin data, then it'll calculate your DO2, Some of these older, like CDIs and all that can calculate DO2, but bottom line is, nowadays, you can, or just bust out a paper and pen, calculate it yourself. Especially if you're,
open the app.
Open the app. Yes.
Everybody, open the app. It's $2.99.
Yeah. I've actually used that app the other day when I got
selling
back.
the app.
We got Joe convinced me to get the app too. I didn't know it was too. I didn't even know the app existed until my first day here with Joe. And then he saw me trying to calculate flows the old school way because that's just the way I do it. And he's like, use the app. And I was like, what app? And then he showed it to me. Went home, bought it that same day for $3. Come on. Like that, $3 doesn't buy you anything anymore in this day and age. If I can get an app that makes my life easy for it.
Everybody heard that?
Yeah.
Okay.
It's true. This is not because I'm an employee. This is my real thoughts. As Joe said, we're all honest here. If I didn't like something, I would tell him, and he knows that about me. I'm not quiet about some shit I don't like.
No, you're not. No.
So that's just the way I am. So yeah, let's move on here. So anemia, especially in perfusionists, anemia on bypass doesn't exactly raise a red flag. It doesn't really show up with like a green, like a flashing light on our pump. It speaks usually through physiology, right? That's how we figure it out. Common causes of it are, like I said, hemodilution, surgical bleeding, especially if you're doing like a redo, redo sternotomy. God forbid they got all this scar tissue, you know what I mean? You're going to have a lot of bleeding in there. Or, of course, in the case of most of our patients nowadays, pre-existing anemia. Shout out to like chronic renal failure patients. We do a lot of those too, Those guys they're going to come in anemic, So we don't chase the hemoglobin number in isolation. I've kind of said this many times. I'm going to talk about these other 4 things again. I'm going to talk about them about 3 times because my take home here is and I'm going to beat this into you guys. I don't want to do it. It's just good this way. But SVO2, lactate, cerebral oximetry, NIRS, urine production, these things are, take them into context with your hemoglobin number. It'll make your life so easy. Hemoglobin can get scary at times, but I mean, if you're doing everything, your SVO2 is not dropping, it's above 65, your lactate's not climbing, it's low, like 2.5. Your cerebral oximetry hasn't changed from baseline, or even if it goes down a little bit in baseline, not an alarm, You don't need to do nothing. So when do you act? You know what I mean? Like you act if, like what I said, if your SVO2 goes below 65%, your lactate starts climbing above 2.5, especially over like a short period of time. It's basically like your cells screaming, oh man, we're anaerobic here, like help us. If your NIRS fall for more than 20% from baseline, it basically means like your brain is on the struggle bus, man. Like, and plus your anesthesia will be all over you if those NIRS fall. Trust me, they will not let that go. Like they will tell you instantly. All the other numbers, they don't really see them as much as we do, but that one, they're constantly monitoring it.
Those that believe in it.
Those that believe in it, correct. So
I do think it has value.
I agree.
I think it has value. It's a very good early warning. It's not perfect.
Maybe we should talk about that one day.
Yes, I think we should. But I mean, but you have those studies that were done,
Yes.
Patient or pumpkin, and they showed that you can be dead, have your brain removed from your skull, and still get a number that is consistent with life.
Yeah. No.
So there are issues.
There's
But if it's working and it's trending and it's going down, at least it gives you a warning.
Exactly.
And I think
that's what we're using it for,
and
right?
I think it really works better than that. I think it's pretty good.
And that's
I used to be against it.
Really?
But I'm not anymore. I think that it actually does have value.
I take it, like you said, as a trending number. That kind of gives us something else to look at. Mm-hmm. Should you only look at the NIRS? Absolutely not.
No, but if it's bad, you should investigate why.
Especially if it goes down over like a 30-minute time. You know what I mean?
Right, or down on one side.
Yeah, or down on one side. Exactly. See, stuff like this. Again, see, guys, that's the name. That's the name of medicine right there. Don't just look at one number. Don't just. You got to look at the whole picture. You know what I mean? Medicine, we are a whole picture type of discipline. Any one number can do anything for any reason at any given time. And if you're only looking at one number, like for instance, hemoglobin, it can go down to below 6.5. But like I said, if these three things are good, if your venous stats are good, everything else is good, then do you need to transfuse? Probably not. I mean, you know, probably
Not at
shouldn't.
that moment.
Not at that moment, especially if your DO2 is good. You got DO2 of 350, then
And if it's an 18-year-old patient,
exactly. See, then there's
otherwise healthy.
Absolutely. So,
but if it's a 72-year-old little woman,
yep,
she's getting blood.
Yeah. Oh, they're gonna make you give blood. You won't even get a.
I don't need them to make me. I'm giving it.
Perfect. So we're gonna talk a few of those clinical scenarios, in a little bit. It's basically like Joe just said. You got to look at the patient. Don't. It's as I had mentioned early at the very beginning. And me and Joe talked about medicine. Each person is different. Their situation is different. Their comorbidity is different. Why are they on the operating table, right? Like, all this matters. If it's a COPD patient, is it a heart failure patient? What was their pathology that landed them here,
Mm-hmm.
Do they got working kidneys? All these little things matter. Is she some 72-year-old little lady? How well will they compensate on their own? 18-year-old, you don't got to worry about them.
And we're going to put a 56-kilo little old lady on the exact same pump.
Exactly.
That we're going to put somebody on who is 6'4".
Correct.
260 pounds.
Right.
Now, then that doesn't make sense.
No.
And that's part of the problem, because in the past I would go and, like when I was working at a single center, I would call and order a pediatric oxygenator.
I was just about to say that. Do you think we should do it pediatric style?
No, I've done that
okay.
many times. I think that's beneficial. But
right.
I think that it's hard to do in the days of custom packs and pre-connected and all of that stuff. Now you have to say, okay, well, it's worth the contamination risk to separate this oxygenator out and change it for another one. We probably could do that.
Correct.
I think there's things we can do. But that would also require us knowing in advance things about the cases, and most of the time we have no idea.
Right.
We know we're going to do a heart.
Right.
Until we walk in there and look and see what is the procedure, we don't know anything. We don't get involved in the patient prior to the actual operating room, which is a philosophical issue. It's a good conversation to have, but one that confounds the issue for us, makes it much more complicated because of we don't have that access.
And some of these hospitals,
nor do we have that expectation, right?
Some of these hospitals don't even give us access to a proper history.
This is true.
You know what I mean?
Please, I'm so sorry.
No, you're okay. Chime in, like I said, anytime.
Well, I'm not letting you finish.
No.
And we're going to run out of time.
Okay. So, let's shift gears. You remember I told you that, there's another side to anemia. This polycythemia. It's the opposite. So now on paper, right? It's when you have too much hemoglobin. On paper, that sounds amazing, right? Like, ooh, that sounds like the dream. More oxygen carrying capacity, more delivery, more everything. But in practice, nah. It's like adding more cars to an already jam-packed freeway. You're not actually gonna get anywhere. Hemoglobin when it goes too high, the worst thing that could happen, especially when you're on pump, is we increase our viscosity. That is highly dangerous, high viscosity when you're on pump. Blood becomes thicker, and microcirculation, the capillaries, they will suffer.
But wait a minute, hold on a minute. I've heard this before.
Let me guess, you said it.
I'm walking around right now with a hemoglobin of 17.
Okay.
That's my last checked hemoglobin.
Okay.
And my capillaries look like they're perfusing just fine.
Sure.
So what's the difference between me being here with my heart pumping this thick shit around versus being on bypass with it being pumped around? Why would that create capillary sludging, unless you were talking about profound or at least beyond moderate hypothermia?
Well, that comes down to Joe.
That's a different issue. But why at normothermia would a hemoglobin of 15 or 14 or 13 or 16 on pump make any difference as to the flow of that blood through our vasculature and our capillary beds? To me, that doesn't make sense to me.
See, that's another argument that's another big argument in perfusion. Pulsatility versus continuous flow. Now, that's something we can argue day and night.
Oh, I have no problem.
There are people that'll say it's because of the pulsatility, Joe.
I have no problem with pulsatility.
Sure.
But then you also have to take into consideration that every new total artificial implantable heart,
they're all continuous.
Are continuous flow pumps.
ECMO's continuous.
And our bodies are designed with pulsatility. That is true.
Sure.
The question is, which came first, the chicken or the egg, the pump or the system, the circulate, the other part of it.
Right.
And that's part of the issue is, I guess God couldn't figure out how to make a centrifugal pump. He had to have one that beat like a muscle. Okay, we'll do it this way.
It was the
seems to work.
He couldn't make a continuous battery. He made a battery that needs a second, to recharge.
But but there's a lot of things that happen from that.
Right.
Vascular distension, surplus hemodynamic energy downstream as it continues to flex and then constrict back to its normal shape. All of these things help with flow.
Right.
And I do get that. But once you get to
the capillaries,
the arterial level, so right down to the very prior to
once
the
you're
capillaries,
microscopic is what you're getting at.
Your continuous flow at that point anyway.
Right. Yeah.
So it's really an interesting issue. I don't think loss of pulsatility alone is enough to cause this capillary sludging issue. I think if you're very thick and you're freezing cold, it could have an impact. I think there.
No, it would then. If you're cold, for sure.
Could. So So generally speaking, I will hemodilute people as I'm cooling them deliberately and try to keep their hematocrits down about 18, 16, somewhere in that range.
As you should.
And then concentrate off that or diurese it off and let them thicken up and give the blood back as I'm warming back up.
Right.
That's the way I do that. But I don't know how much of this belief in capillary sludging for that reason is real. How much of that is actually real? Or are we theorizing this?
They have studies, Joe. I mean, and again, studies can always be skewed one way or another, right? Like that's the problem. Is every one study that'll support one thing, you'll have another study that supports it the other way, and both will have data.
Yes.
Right? And that's kind of, I guess, what's so dangerous about science is people, established people that have done many studies will come around and tell you, well, this is the way to do it.
Right.
You know what I mean?
Right.
Right. And it might or might not be.
Right.
I guess clinically, you just got to kind of work with what you're given at the moment of, it comes down to, like I was saying,
and do you
SVO2, DO2, or if you're delivering and you're getting back, then you're probably good.
Yeah, true.
Right?
True.
So, let's see. So yeah, that's polycythemia, as it how do you deal with polycythemia? On pump, we,
plasmapheresis.
Yeah, there's that. There's pull some volume off at the beginning, put it in a bag. Seen that done many times.
Or apheresis. Yeah.
Yep, apheresis. Isovolemic hemodilution. Sorry. Take off volume, put back colloid or crystalloid. Based on whatever volume you took, so you don't cause a hemodynamic negative situation. These are all things you'll see various things done. It's not common, but you do come across occasionally the polycythemic patient. Or patients with COPD, they also come with hemacrits that are crazy too. So transfusion thresholds is what it was all about, So let's get real. Transfusion decisions, as I've told you now, they're not easy. It's not just like, oh no, hemoglobin is 6.9, quick, grab the blood. It's not that easy. You know, you got to talk. Like, you got to think. You know, is this a stable patient? You know, with no bleeding? You know, you can wait probably if the hemoglobin drops down to 7. You know, is it a cardiac patient with coronary artery disease? You know, low EF. Those you got to be a little more cautious. You know, maybe aim for like a little bit higher, like an 8 or something. You know, on pump, you seeing a low DO2, a low SVO2. You know, is the lactate low? Trending to up. Sorry, not low, but trending up. You know, in those cases, you might want to transfuse, you know, especially if it's the hemoglobin's even at an 8 or a 7.5. It is just, you got to kind of play it by ear based on what you're seeing in front of you, you know. And like I said many times, it's not just one number. You know, what's the perfusion pressure? You know, is the MAP low? You know, is oxygen delivery may already be compromised? You know, is the patient acidotic? You know, like I told you, that'll decrease oxygen's affinity. Sounds helpful, but what it means is that the tissues are already struggling. You know, are the organs perfusing? Check the kidneys, you know, the brain, the gut, high-risk patient, you know, elderly, like Joe said, you know, that 72-year-old lady with the low weight, you know, septic patient, vasoplegic patient, you know, poor reserve patient. You just got to look at the patient. You know, we both said many times, you know, always remember that blood's like, you know, it's a biological product. You know, it's not an inert volume filler. So when you give it, you need to remember that it will come with some negative things like I told you before, you know, immune reactions, trally, infection, cost, iron overload, all these things. So is that worth it? You know, you're the professional at that point. It's your call. You're the one that you have to think about it and decide if you want to transfuse or not, you know? So there's some evidence, you know, some actual trials that came out. There was the TRICK trial in '99. You know, basically it compared a restrictive strategy. They wouldn't transfuse until the hemoglobin was 7. And then they compared it to a liberal transfusion, like anytime it went below 10, and they did this in ICO patients. And in that trial, there was no difference in mortality. In fact, the restrictive group did slightly better. There was another one in 2015, the TRIS trial. Septic patients were the target group in there in the ICU. Same story, no harm from holding off till 7. There was the FOCUS trial in 2011, you know. Those were with elderly hip fracture people. Again, same thing. But, you know, the take-home message on those 3 trials was restrictive transfusion strategies are safe for most people. But now here's the caveat, you know, and this is what you have to remember, that none of those trials were done on patients on bypass, okay? You have to, what did I say at the very beginning? You have to understand, we changed the game with the hemodilution. We changed everything that would be like what an ICU patient would see. Once we hemodiluted, once we went on pump, we're now dealing with a whole different beast. You know what I mean? So you're flying without a radar at times, you know what I mean? So you have to be your own autopilot. You know, you have to be the radar. Your population is different. You know, you're altering temperature, pH, CO2, volume status, oxygenation. You're doing all this at once. You know, so this does not happen anywhere else in the hospital except when you're on pump. This many changes over such a small period of time. Okay? So yes, use the guidelines that I've been covering, but you don't let them handcuff you or your clinical judgment, you know. Guidelines are a map. You know, it's the patient in front of you. That's like the terrain, though. So you got to use your eyes, your brain, your monitors. Trust your instincts. The instincts are key. You know, trust your experience, like in Joe's case. You know, he's been seeing so many patients that he probably he already knows what he's going to do, you know. Me, I've seen patients in ICU settings, you know, like I'm still new to the OR game. So I might be more reserved, might follow the guidelines a little more closely, you know, than somebody like Joe would. You know, we practice differently. I eventually will get to a stage where I'll know what I'm going to do even before I do it.
Maybe.
You know, maybe. Mm-hmm. You know?
Mm-hmm. Yeah, I know what I'm going to do that I don't know what the hell I'm doing at any given moment of every given day.
So I retract then. Joe has no clue what he's doing at any given moment of any given day.
I only think I do.
All right, so we can't talk about every... Oh, boy. Hold on. My little earpiece came off. Okay, so calculating oxygen delivery. I'm going to just breeze through this. It's a formula that every perfusionist, I feel, should know. Should be at the tip of your tongue.
No, they should just have our app.
And the app.
We use the same formula.
Yeah, we do use the exact same formula, correct. And I did check that, and you can even see it by hitting the little eye. That's your pump flow, right? The 1.34 times the hemoglobin times the SaO2. That part, what is that? Well, that's that 98% part that I was talking about. That's the oxygen that's bound, that's bound to hemoglobin, all right? So the 0.003 times the PaO2, well, that has to be what's left, right? That's the other 2%. That's the part that's dissolved in the plasma. People say it doesn't matter, but it can in certain situations. I'm not going to get into that. So what does this mean?
Hey, Matt.
Yeah. Yeah. So what should your target DO2 be on bypass? Well, the books and everything say above 270. That's the number they say. And that's the number you should see. But again, like I've said many times, you have to look at the whole picture. It's not just one number. But yes, a lawyer is going to use that number. So you should be above that number. And they love looking at this number, apparently. That's what I've read. I've never been to court yet, and I don't want to go. One day I'm sure it'll happen. It happens to everybody.
Sometimes you just can't get to that number.
Yeah, exactly. Sometimes you just can't get to that number. All right, so these are those things I was talking about, SVO2, lactate, NIRS, MAP, urine output. I'm not going to talk about them again. Urine output. I didn't talk enough about that. Urine output. We have all these high-tech gadgetries and all this, but man, urine output is still like the GOAT, when it comes to real-time perfusion. Like, if you're making urine, you're moving in the right direction.
But if you're not making
urine, it's not just that you're not perfusing.
Correct. There could be many other factors.
Correct.
So urine output is actually, I think, well accepted today to not be a very good surrogate of renal perfusion
Under
on
perfusion.
part of right.
It's good for to indicate perfusion.
It can validate a positive, but
correct,
not a negative.
Not a negative. Correct.
There you go.
So as long as you're making urine, then you're doing this. But like Joe said, if you're not making urine, you need to look at more than just thinking that you're not perfusing, because you could not be making urine, but then your NIRS are like amazing.
Yes.
So yes, you're perfusing. And what do we care the most about perfusing? The brain, right? Like that's the name of the game.
Well, and I'm not trying to make it. I've really made it hard for you to get through your lecture, and I'm so sorry.
You're fine.
But I know I heard you over there. Don't worry. My staff is reminding me that I do this a lot. Interrupt. But here's the thing about urine output. And I think this is really important for our colleagues to grasp.
Right.
This concept. So we have natriuretic peptide.
Yes.
Right.
And
we have right.
Right.
And they live in the atria.
Yes, they do.
Okay.
That's what the A stands for in A.
And yep. And so when we go on bypass and we collapse the heart,
right,
we now take that stimulus completely away
right,
from the kidneys to gauge whether or not
right,
the kidneys need to be shedding some
right,
fluid here.
Yeah, right, because stretch is the stimulus.
Stretch is the stimulus,
correct,
exactly.
Right.
And so when we take that away, and that's why you frequently see either oliguria or anuria
during a pump run.
Right. And there's so many more factors that influence it. But if you are making urine, I agree with you, there's never a negative to that unless it's diabetes insipidus or something. You knocked out their pituitary gland.
Right, that's different.
You did something stupid with a bubble.
Right.
But you know what they say about bubbles.
Right.
No bubbles.
But you would know if you're dealing with DI before you come into the operating room.
Unless you caused it.
Yeah. We wouldn't cause it.
Could embolize it.
Yeah, that's true.
Could.
Straight to the pituitary, yeah.
It'd have to go right there,
it would have
but
to
it
go
could.
right there, though.
But with that said, we're getting off track. The point I'm trying to make is that it's validating your kidneys are working if you're making urine.
Right.
It's not validating your
if you're
kidneys
not,
because of those other things we just discussed. One of them being you lose the stimulus on your BNP in order to stimulate the kidneys to produce urine.
Right.
Sorry.
You're fine.
I think it's an important concept.
What you're doing, you're not making me mad. I'm okay with that. But I think you're making David mad back there.
I know I am. Go ahead. Dude, we're going to end on time.
David's the guy that has to keep us on track.
We're going to end on time. Don't worry.
Okay.
Don't worry.
So I got some case examples. Just, for instance, you got a patient with like a 6.5 grams per deciliter hemoglobin, which seems low, right? SVO2 is 58%. That means tissues are extracting a lot. Lactate's 3.1. That's not good. That means they switched to aerobic metabolism. MAP's 55, which that's like the bottom end of the number that they recommend that we be at. They say that kidneys suffer below 55. That's what's written in the books.
It could be.
It could be. Yeah.
Hypoxia too.
Yeah, that's the magic number, Joe. It's written in multiple books. I've seen it.
The PO2 in the glomerulus is probably 25.
Exactly. Maybe, yeah.
At best. So and that's the arterial side.
So in this case, should you transfuse?
Do you want me to answer the question?
Absolutely. I want to know what your answer is.
There's not enough information to make the decision.
No? Why?
No. I want to know what your flow is. I want to know what the patient's weight is. I want to know what the patient's temperature is. I want to know what the patient's, I want to know a lot more information here to make that decision. This could be a flow problem.
Okay.
Right? Mm-hmm. The SVO2 being low, lactate being up, hemoglobin 6.5. If you're flowing enough, you shouldn't have those numbers.
Right.
So if you're flowing, if this patient is not, there's no other reason than that we can't flow more and we have to do something to increase delivery. It really comes down to that. Is the fundamental problem here it's a delivery problem, but is it because of content or is it because of speed of delivery? And if it's not speed of delivery, then yes, I would transfuse.
Okay. So I would agree with you. I don't think I would transfuse either. Not without knowing the whole scenario. The site I pulled this from, they said transfuse.
Well, I mean,
and again, they're basing it completely off of the fact that the SVO2 is trending down, the lactate's trending up, but they didn't tell us it's trending up. Well, they just tell us it's 3.1. It could be trending down.
Hemoglobin of 6.5. Though it
usually means
low, but an SVO2 of 58%, that tells me that you either have increased extraction, your O2 is up for some reason,
right,
or you are just simply not delivering whatever you're delivering fast enough. That's 6.5, right. But 6.5. If you said it was 5.6, maybe I'd have been a little more. Yeah, absolutely. But in this case, I think that it's questionable.
Okay.
But not unreasonable if everything else is the same and we just need to get the hemoglobin up to perfuse well enough.
Right.
I have no problem with that.
So, again, they say yes.
Okay.
Only because, again, evidence of inadequate oxygen delivery, there's an oxygen debt that you're seeing. You don't want to get behind in this debt. That's the logic that they use on this.
So it shouldn't be, should you transfuse? It should say, should you increase DO2?
With flow? That's what you're saying.
It doesn't matter.
Yeah.
Transfuse could be one of those things. Yeah. So you need to tell them they're wrong. But go ahead. Next.
Okay.
Not that I'm humble.
No.
Because I don't want anybody to think that I don't have an opinion.
No.
Okay, let's see this one. Post-cabbage.
Post-cabbage.
1.5. Stable hemodynamics. No, absolutely not.
Exactly. This one, they said no too. Patient's compensating, lactate's not high, SVO2 is good.
No,
MAP is solid.
Anything over 1 on the lactate, I get kind of nervous.
Do you? But it's still not.
I get very nervous when it's above 2.
But would you think it's, even at 1.5, that's not like a transfusion sign, though?
No, but
and you're right.
But there's some tissue ischemia somewhere.
Yeah. Mm-hmm. Well, I mean, he's cabbage, Joe. There's going to be tissue ischemia.
Sure. Yeah, maybe. Shouldn't be.
No, there shouldn't be, but... Especially post, right? Like we're assuming that we dealt with that.
Absolutely.
Hopefully.
Yep.
So the summary, basically, again, hemoglobin, not just a number. That's kind of what I've been beating into you guys from the beginning. Balance hemodilution, oxygen delivery, DO2, lactate, monitor everything. Again, DO2, Joe's app. Remember that. Calculates it for you. If you're above 270, then...
In fact, put the app up there.
Absolutely. Put it there.
No, I can open it on my iPad, can't I? I mean, let's open the app. You know what? We should have done this while we
Oh
were doing
yeah,
that. I
we
could have done
calculated
this.
We could have made up a flow and calculated that.
That's what we're gonna do.
patient's
We're gonna do it.
VO2.
We're gonna do it right now. Are you kidding me?
Absolutely.
I don't know where it is on here. Do you know where it is? Oh, there it is.
Right? There it is.
There it is. Okay, it's up.
Oh yeah, there it is. I see it.
Okay, and there you go. Okay,
There it
so
is.
now we're gonna go.
Let's go back to that one patient.
We're gonna go to perfusion.
Okay.
So we could go to perfusion. We could go to ECMO. They're both gonna have it. But let's do DO. You want to? What do you want to do?
Let's do this
quick
patient.
tell?
Let's do that one that they said
DO2I.
that we
So
would.
I'll
Yeah,
look
let's
at
do
DO2I. Okay. Hemoglobin is 6.5.
Yep.
Saturation is 100%.
Yep. It's gonna be 100 because we're on pump, right?
Okay.
Mm-hmm.
PaO2 was
We'll call it 500.
500.
Yeah. What the hell? Why not?
Cardiac output.
We'll say we're at 100%. FiO2. And
what's your
whatever.
cardiac output?
Let's call it. Let's see. Let's just call it 4.5.
4.5.
Yeah, 4.5.
4.5 liters per minute.
Flowing at a 4.5.
And BSA is what?
2?
2?
No, 1.85.
1.85.
Yeah.
1.85.
Yeah.
Calculate. You're at 252.3.
Go up to a BSA. Go down to
So-
a BSA of 1.75. I just want to see what difference it would have made.
267. You're
Yeah,
almost
see,
there.
That one's almost there. So our patient would have to be pretty small with these numbers.
So
to
let's
lead
go
to
to
a point where we would.
let's go to one. Let's go back to 1.9
Yeah, let's go to 1.9
and
let's
calculate. Now 246. Now
let's say we increased
the
our
cardiac
flow.
output 1 liter.
Yeah, right. Let's say we increased our flow. Let's
5.5.
say we had the volume and all was well and we could do it.
300.
Yeah,
Let's go
see?
to 5 liters. 273. Just by going, let's lower this PO2 to 350.
350. Yeah.
Make it something.
Again, that's not going to change it too much.
It
though.
did. It brought it down.
It does bring it down.
It did bring it down. So I'm going to go 5.25. 274. So there you go.
There you go. See?
If you can do it.
If you can do it.
But let's go back. You got no volume. You're at 4 liters. That's
Okay.
the reality. And you're way down at 208.
Yeah.
So there's no way I'm going to flow enough. I don't have the volume. So let's
Correct.
change this hemoglobin to 8.
You're
It's
still, gonna be
still
low.
not enough.
You're still going to be low.
Let's go to 9.
It's probably still not enough.
280. So
280,
somewhere between
barely.
8.5 and 9 is where you're going to need to be.
So you
on
would
your
need to
hemoglobin.
give 2 units.
I would give 2 units,
Yeah.
yes. Well, I never give 1 unit
Yeah,
of blood.
obviously.
You give
if
one,
if
you
you're,
give 2.
Yeah, if you're
That
giving,
doesn't make
giving
sense.
2. Yeah, it doesn't
But
make
this
sense.
is a very useful tool for being able to
Absolutely.
look at that stuff. And
And
you know,
to understand the equations too for all you future students or
You can-
students or even new perfusionists like myself,
yeah.
you can really figure out how you would practice,
Yep.
just by playing around with this app. Again, it's one of the most important equations that we do, DO2. It'll drive entire legal issues for you or against you, So,
Absolutely.
So, I mean, if you're delivering, then all the other numbers they kind of become not important if you're delivering,
Right.
So,
And we're taking these very big concepts and we're reducing them down to this looking at it under a microscope.
exactly.
And the problem with that is that everything is interconnected. So the effect on one thing affects everything else.
Right.
And everything else that gets affected then also affects everything else. So biology of the human organism is incredibly complex, and there's organ crosstalk. People don't really think that the kidneys actually talk to the heart. The heart actually talks to the kidneys. The lungs, the kidneys will affect the lungs, the lung water. There's all kinds of things that organ crosstalk occurs
absolutely.
in. And I think that
I mean, you kind of
lose
just touched
sight
on
of
it
that.
earlier with the natriuretic peptide,
Correct.
right?
Correct.
So,
There's a lot of things,
Right.
that you can get. Okay, that was excellent. Very good. I am so sorry you had to power through and making
Okay.
it took you your hour lecture. But of course, I took up a lot of your time in my opening remarks. Actually, you did
that's
really
okay.
good. You were right about it.
I just want to put my email address. If anybody
Yeah,
has any
throw
questions,
throw his slides back up, please.
I got it. There. Well, yes. So
Yeah, thank you.
there's my email address, Samir Patel at het.us. Anybody have any questions? feel free to email me. I'll do my best to answer them.
And I love that. Stay curious, stay critical, stay compassionate,
Caffeinated.
and stay caffeinated. All of those.
Caffeine, it's your best friend.
And don't forget to stay tequila'd. Tequila is better.
Tequila. I didn't know how you feel me writing that. I was like,
I'd have been fine with it. Okay. So let's go ahead and jump right into mine. I'm going to get done on time. We're going to go ahead and start. And here is an image of what is 10 of the top 50 greatest rappers of all time. There's Jay-Z, Eminem, Snoop D-O-double-G. I guess that's Biggie Smalls, Tupac.
Tupac.
You know, they're both dead.
Yes, they are.
They got shot in Vegas. But I don't know who the other dude is.
That's Drake and Nicki Minaj.
Yeah, there you go. So you know him. All right, there you go. So we're there now, right? We all get it. That's rapping. Well, that wasn't very helpful. Let's try that again. Okay, there. So what are the purported benefits of rapping? Decreased hemodilution, which leads to decreased transfusions, which makes no sense. We'll talk about that here in a minute. Reduced AKI rates, makes no sense. It just doesn't even make sense. These are published things. I'm not going to put all the references from everything because it comes from so many different sources, but these are things that we all know to be understood about this. Improved oxygenation, decreased vent time, decreased length of stay, decreased cost. I'm going to show you that none of that's real. I mean, this is just all made up nonsense. The possible risks of rapping: hypoperfusion, air entrapment or entrainment, and mishaps. Okay. So in this study, this article here that was out of Brazil in 2011, retrograde autologous priming in cardiopulmonary patients and adults, effects on blood transfusion and hemodilution. Now, if you look at their slide here, basically what you see is the blood from the venous line here coming down and going to this collection bag that's going to be used for the blood. And then when they go on, they will obviously clamp here and then flow up this way until it becomes blood, and then clamp here, and then the flow will go normally as it should to the patient. So that is a methodology for creating this full blood prime system. And most cardiopulmonary bypass systems are going to have between 750 at the very least to probably 1,300. There's bigger ones that go bigger than that, but I'd say somewhere between 1,000 to 1,300 cc's is a pretty typical priming system that's going to take to prime it. That's about what it's going to take. No matter how short you make your lines, how small you make your lines, unless you're doing, again, pediatric surgery. We're not as adults.
That's like the bare minimum you're talking, right?
We're talking totally different.
Like after you ran out everything, you got maybe 200 in your reservoir.
But that's only 1,000 cc's just to have it primed. That isn't an operation level.
Right.
That's not an operating level. So you have to have level in your reservoir, right?
Absolutely.
So to react. So really you're probably looking at 1,500.
Okay.
That is going to be way more than 20% of our average patient's total blood volume.
Absolutely.
Now, let me get through the lecture. Here are the things, the parameters that they measured: age, gender, weight, EF, crit, pre and H&H, CBB time. Not sure why that's even relevant.
Yeah.
Cross clamp time, RAPP or no RAPP, what difference does that make? Distal anastomoses number, what difference does that make? ICU stay, post-op bleeding, first post-op, I'm assuming BUN, and saved priming in milliliters. So all of these things. Okay, so let's look at it. Just looking at the things that probably really matter. is they saved 729 cc's on average. Okay, that's not too bad.
Right.
Your ICU days was 3 on the
0.1.
RAPP group and
Yeah.
2.8. Really no difference, but it
Yeah.
is certainly a little less on the post-op bleeding seemed a little higher on the RAPP group than the control group. And the BUN seemed also higher on the RAPP group versus the control group. I found that sort of odd. And then your pre-crits were the same, but I'm looking for the post-crit. And I'm not sure where that's going to be, but hopefully we'll find it. Here's our mean arterial pressures, RAPP group here, control group here. Really no major difference in that. I would say that those are essentially the same.
Which is shocking because of the whole washout with the catecholamines at
Yeah.
the beginning. You would think that the RAPP group would have a better going on map.
One would think.
One would think, right? Like,
And
yeah.
then our blood flow, blood flow was not surprisingly, I'm sort of not surprised by this, that the blood flow was higher in the control group. But there was another factor in this study that I thought was very interesting. Here's the SVRs throughout. And I have to tell you, I don't know who the hell these people are, but they run some really high SVRs. I don't run my SVR up to 2,000 ever.
Yes.
I mean, if I'm going to stay somewhere between, I mean, I think that's abnormally high. So I don't know what they're doing, but that's really high, in my opinion.
Using a lot of vasoconstrictors.
Yeah, and here's graphs, just pretty graphs to show essentially the exact same thing. Total volume of crystalloid used during CPB and diuresis. So total crystalloid used was obviously higher in the control group for obvious reasons. And intraoperatively, it was a little higher. And postoperatively, it was still a little higher. Why, I don't know. Okay. In their discussion, which was set out to validate RAPP as a technique. Despite the advantages attributed to the use of RAPP, few studies were carried out in the last decade. Although recent isolated studies confirm the benefits of RAPP, and they're poorly done, all of them,
Sure.
at least 2 studies in a meta-analysis are not favorable. Okay?
Okay.
And I think that's really important to point out. Now, in this particular study by Murphy and his colleagues, failure of retrograde autologous prime to reduce blood use after cardiac surgical procedures. And here they have all of their basic demographics and so forth in terms of how they matched the cases together, 201 to 192. Again, they looked at pump duration, which makes no sense. Cross clamp duration makes no sense. Hematocrit, that probably makes sense. In the no RAPP group, 35, RAPP group, 36. This is pre. And then on bypass, 22 in the no RAPP group, 26 in the RAPP group, which is significant, very
Yeah, that's
significant.
But again, you're wrapping, so it should
Crystalloid
be.
infused, well, and there's another factor that doesn't get discussed in any of these studies. Do you know what it is?
What?
Do you know what it is? We're not comparing it to hemoconcentration.
Oh yeah, okay, I see what you're saying.
So, and I'll get to that because there's a point in here
Yeah.
that I really found fascinating.
Yeah.
Fascinatingly ignorant. Use of inotropy was 0. Crystalloid used in the no RAPP group was 2,700, just a little bit higher in the RAPP group, which I found interesting. Right,
Yeah,
that
is
was
interesting.
interesting. Okay. So this is basic information that you can look at. You don't really need, but this is the important part.
Right.
Packed red cells on pump. These are 288 versus 257 patients. So 38 versus 32, 88 versus 60. So the NOR transfusion rate was lower in the RAPP group than in the no RAPP group. Not at all surprising, but this is what I'm trying to say, is if I have 2 liters of volume in my tank and the CVP on pump is still 3 or 4 or 5,
doesn't matter.
And I'm and I just give blood for a now hypervolemic patient, instead of just removing the excess water, avoiding the transfusion altogether. But no, you can't do that because, oh no, ultrafiltrational bypass causes acute kidney injury and renal failure. Wrong.
That's what they say, Joe.
Again, wrong. So let's move on. Use of FFP was similar. Use of was, you know, the little bit of a difference there, and platelets kind of the same thing, just higher in the RAPP group. Here's basically the variables of the patients. And here's their assessment. Hemodynamic instability can develop when blood is drained from the patient into the arterial and venous lines. It may be worsened if pre-CPB autologous blood donation has been performed. I don't recommend doing that either.
I don't.
Reduced arterial pressure, systolic blood pressure less than 100, was treated in a standardized manner. So that's pretty damn high. Oh, systolic, okay. Because I'm looking at their SVRs. And they used phenylephrine and so forth. The incidence of hypotension during RAPP was not determined in this investigation. However, hypotension not responsive to these measures occurred in less than 1% of the patients. Although induced hypovolemia may potentially adversely affect organ perfusion, the time from the start of the RAPP until onset of CPB was typically brief, less than 5 to 8 minutes, which I completely agree with. You know, you've got a little moment of shock going on here, you know, and most people recover from shock. But to say 5 to 8 minutes of shock, of poor perfusion is not bad, is not, I don't think, something that I can necessarily agree with. I don't think we know, really, at the end of the day. And if you're going to RAPP, you can't RAPP just your venous line and your arterial line. The oxygenator in the centrifugal cone has much more volume in it than anything else. And so you don't RAPP that, you've got to RAPP it all. And now you're really talking about taking out of the patient much greater than 20% of their cardiac output, and they are going to be hemodynamically unstable. They are going to go into hemorrhagic shock.
And that is
a harsh reality.
That is why I don't agree. I don't like the whole idea of displacing volume with.
Then I met Emily Foreman.
Okay, who's
probably one of the absolute best perfusionists I've ever had a chance to spend some time talking to. She came in virtually. She published this study, and she came up with a method which made so much sense to me. She doesn't RAPP at all. And what they did was they came up with an actual multidisciplinary approach towards treating the patient preoperatively and perioperatively and postoperatively to minimize the amount of excess blood loss from sampling and hemodilution from all of the volume anesthesia tends to give, all of the volume pre-op holding tends to give, all of these things. So they basically optimize their patient's fluid status prior to coming into the room.
Oh, okay.
So there's no need for all of these things because if you're going to RAPP and you increase the patient's circulating volume by 1,300 of crystalloid, so you have a now full tank, and you're able to drain all of that out and RAPP the pump, what did you do? You gave 1,300 to displace 1,300.
Right.
What was the point?
Yeah.
I'm still trying to understand it. Anyway, moving on. But anyway, this is what they did. And their technique essentially obviated the need completely for RAPP. Retrograde Autologous Prime is a process Perfusionist use, initiation of pulmonary bypass. RAPP is performed by replacing, all of that. Intensive care unit, 30-day mortality. Okay, this is her continued lecture. So here you see the RAPP and no RAPP, and you start seeing totally different numbers than you saw before. Very, very much
Right.
consistent with what you would expect. No change in creatinines, and they each had plenty of patients with histories of either end-stage renal disease or chronic kidney disease. Again, they looked at all of these different things. None of that makes any sense to me. And here's their urine output on bypass. Their urine output on bypass was great.
Oh, yeah. That is.
I mean, I don't ever have cases like that. But their AKI rates, look at that, still 4.9 and 4.8%.
Oh, yeah.
Isn't that amazing?
It didn't change that much.
No, it really didn't, because there's something else going on. Something else going on. I just don't know what that is. Now, the non-RAPP group, they died more in 30 days, but I don't know that we can really say anything about that. I don't know what the reason for that is. In this retrospective study, we examined the impact of RAPP in a heterogeneous population of 2 consecutive patient groups undergoing CPB. Data analysis showed that the RAPP and non-RAPP group had equal demographic, preoperative, and CPB characteristics. Our investigation indicated there was no statistically significant impact of RAPP on PRBC transfusion rates, DO2 index, incidence of postoperative AKI, intraoperative albumin administration, Vendelheim's, ICU length of stay, 30-day mortality. We did observe a statistically significant increase in albumin infusion in the ICU postoperatively in the RAPP group, although the small volume difference was not clinically significant. While several published studies show there are potential benefits of RAPP, our all-inclusive analysis as an active cardiac surgery program found that there was no significant benefit to RAPP and condensed CPB circuit in our patient population. That was very important, because her patient population, that plays a huge role in what we do. What is the protoplasm that you see on a regular basis?
Right.
And also this very comprehensive team approach towards managing the patient, without there being all of this anesthesia wants this, we want that. The surgeons don't know which they only wouldn't want to cut, and so they're not involved in this. So you've got all these basically it's us as anesthesia fighting over what the best way to manage this patient is. So what are some of the variables? Well, albumin level, COP, cardioplegia technique, pre-op condition, their EF, renal, pre-existing, nutrition, meds, in-house or same-day admit, anesthesia technique. Are they using dexmedetomidine, which, of course, we all know is a very potent vasodilator, and in order to keep the blood pressure up, you have to give a lot of volume to compensate for it. So your tank, your heart on echo looks empty, but it is, but it's an artificial issue, because your tank, your vasculature, especially your venous capacitance system, has been dilated out.
Right.
So you have much more volume than you think.
Yeah. And that's always like.
Then are you using hemoconcentration and inflammatory mediator or inflammatory response mitigation? And of course, there's always irrigation. Poor irrigation, sucking out the left chest, and you see it coming back, and it looks like barely Kool-Aid, and you're just like, are you kidding me? And you see the level in your oxygenator go up, your temperature goes down, the blood pressure is now a mean of 28. Everybody's going, whoa, what's going on? What's going on? Well, you know what's going on is you sucked out that left chest, and now I have to fix this. Right. So I get very exercised and very irritated when they do that. But all of that irrigant, if you don't have access to hemoconcentration, you're coming off with whatever that is, and you're going to end up with a lot more volume than you needed, and it's all going to go to the cell saver, and it's all going to end up as basically washed red blood cells, and all of the platelets, all of the plasma, everything else is just going to get thrown away.
All the co-factors,
and then you wonder to the platelets, and then you wonder to yourself, why is the patient bleeding? I mean, I don't know. I mean, I think I know, but but nobody listens to me.
Yeah.
I'm not exactly sure why I put this slide on here, so I don't know why I did it, so I'm just going to ignore it if that's okay with everybody. Oh, I put the hemoconcentrator in. Haha, that's what it was. Let me go back. Watch. Look right here.
Oh, my God.
This is all this circuit needs. That's all it was.
That's what happens when
that was cute. And then there's my app. So at the end of the day, I think that RAPP, I say it jokingly that leave RAPP to the rappers, but in reality, I feel that people have just become ideologically married to this idea that RAPP really is a benefit. And I am 100% convinced that it is one of the most incredibly useless and potentially harmful things that we as perfusionists do. And so I have very strong feelings about it, and it's not positive. It's very negative. So my strong feelings, that is. So be that as it may, I am certainly willing to argue my points, because on Friday, our new programming is going to include a stand your ground in the raging inferno. And we're going to this is just going to be, you know, as I said, very open, very respectful, but perhaps heated sometimes. We're going to try to get some voices who disagree with me entirely, and let's fight it out. Let's look at what the facts are and then make good decisions from there. Because at the end of the day, if I'm proved wrong and RAPP really is that much of a benefit, I'm happy to say I was wrong and do it really, really well. I do it because sometimes I have to, because the surgeon has decided, I want you to wrap the patient, but I won't wrap just the arterial line, the venous line. I wrap the entire circuit.
Right.
The entire circuit. I don't like doing it, but if I'm going to wrap it all. Because I don't think we should just half wrap. That doesn't make any sense. You're taking out the least amount of volume in a circuit, and then saying you're doing something, and we're really not. So I think we have a long way to go in understanding all of this. I know that, you know, I say this many times, and I'll say it again, that when people used to ask me what I did for work, I used to try to have to explain it. Like, I'm a perfusionist. Oh, what's that? And I went through several iterations of what the hell a perfusionist really is. But I came to a conclusion about what it is I actually do. So when somebody asks me what I do,
I'm interested in hearing this because I get asked that all the time, and
yes,
I'm still trying to come up with my answer for it.
So what I do is I go to work and I hurt patients.
Yeah,
every time
definitely not leading with that.
Every time we go on bypass, I am causing harm.
Absolutely.
The question is, how can I best mitigate that harm? How can I best reduce the long-term impact and effect that the harm I'm going to do is going to cause? And so I don't want to cause even more harm than I know I'm going to, but I'm going to acutely hemodilute you. I'm going to acutely drain your heart. I'm going to acutely take away your pulsatility and change your blood flow characteristics completely. I'm going to give you massive hypotension for some periods of time while I'm trying to correct that with whatever drugs. I've got to get the anesthesia gas on so that, you know, you don't remember this shit, but I don't have a blood pressure that's going to support it just yet. I'm working on it. And the whole time, there's a whole bunch of other things happening, including somebody saying something about the blood pressure and somebody else saying down on the flow because they want to put the clamp on. Well, go ahead and put the clamp on. The pressure's only 25, so you're fine. And let me just keep working on this. So there's what I do. What I do is try to replace and replicate probably one of the most elegant systems ever designed by nature, or whoever designs us, however, whatever you believe. And I'm doing it with things made of polycarbonate, polypropylene, polyvinyl chloride, probably some other materials in there, nylons and things like that, and it can't be done.
And all kinds of fun coatings too.
It just can't be done. Can't be. It works. It works for most people. Most people can tolerate it, because if they couldn't, so I facilitate an operation being done, and I mitigate the harm that I'm going to cause. That's my job. I'm a facilitator.
I think I like it. I think I'm not going to lead with the whole, yeah, my job is to do harm.
It is.
It is. You're right.
It is.
I don't think people want to hear
when
that.
You open the venous, when you open the venous line,
absolutely, you're draining them,
and the heart goes woof,
yeah,
like that.
Yeah,
the physiologic effect of that in the body is
absolutely
unbelievable, and we never think about it because several reasons.
Right.
People seem to tolerate it okay, but do we really know what happens?
Well, there's that whole group that like supports like isovolumetric initiation, the one where you let off like the arterial line first and then drain venous so that you're giving what you get. But then you can get pissed the surgeon off because then you're not going to collapse the heart, and all of them love seeing the heart
collapse. But I don't think that works. I mean, it's not going to work for that because you still have to drain the right side. The heart is still going to be very empty. We're going to not only empty it, we're going to clamp the damn thing. We're going to freeze it. We're going to make it stop for working at all. We might even open the damn thing up. And it still has receptors that are still going to act on other organs.
Yeah, that is.
Or not act on them the way they're supposed to.
Right.
Because we've taken away the feedback mechanism. We now are that.
Right. We are the feedback.
And when we talk about ultrafiltration next time, you're really going to be surprised to see my view on that. Because in my view, even if you were to just ultrafiltrate your prime volume off, and that's it, it would still be way better than doing this RAPP.
Well, you've told me many times you should, what was it that you said to me? If you don't ultrafiltrate more than 2 liters, you have failed.
You have. Absolutely. Because
that is what Joe told me during a pump run.
I don't want to get ahead of myself and talk about ultrafiltration, but you know, when you were talking about adding, you know, all the dilution that we do and changing the COP, and I was thinking about that, and I'm like, yeah, exactly. So when you start hemoconcentrating and raising the COP,
right,
your PRR, your plasma refill rate, post-capillary increases, and all of this fluid that is in the tissue, overwhelming the tissue, causing perfusion deficits because of essentially tension, from the tissues being edematous, from all of this volume that has been shifted into them because of the low COP.
Right.
Yeah, I'm fixing that, and it's coming back. So how can I possibly hemoconcentrate that much fluid off? They don't have that much volume in their vasculature because it's not in their vasculature.
Right.
And until one of these studies gets done, weighing these patients, weighing them in the moment, every moment that you're operating on them, you would, if you want to understand fluid balance,
you have to weigh them.
You have to weigh them.
And compare them against their dry weight.
And have it so that they're continuously weighed throughout the procedure, because they're not going to lose fat that fast.
No, they won't. It's not during the procedure for sure.
No, not even for the next few days.
No, right, correct.
Right. So that's my view on that.
So
okay.
Any volume change would result in a weight change, right? So
do we have agreed? That's correct.
Yeah.
Do we have any questions from our esteemed studio audience today? If not, we're going to end a few minutes early. David, you're welcome. And we will see you tomorrow for another fun episode with Dr. Samir and Joe. Peace out.